Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I am thrilled to be joined by Dr. Sima Tahir. Dr. Saema is an adult and pediatric sleep and pulmonary disease specialist. She is a quadruple board certified physician who specializes in pulmonary disease, critical care medicine, and sleep medicine. She completed her internal medicine residency at Case Western University at Metro Health Medical Center, and then embarked on 4 years of specialty training, completing a fellowship in sleep medicine at Temple University Hospital, followed by a fellowship in pulmonary and critical care medicine at Drexel University Medical Center. After finishing her training, Dr. Saema moved to New York City at the height of the COVID-19 pandemic and spent 2 years working on the front lines in an intensive care unit. When the city started to return to normal, she delved deeper into her passion for sleep and pulmonary medicine and has recently opened up her own private practice in Manhattan, focusing solely on sleep disorders and pulmonary disease. Her mission is to unravel the mysteries of her patients' respiratory systems and sleep through comprehensive diagnosis and personalized treatment plans. And those of you who are fans of the show and follow my content already know why I'm so excited to have this conversation with her. We're going to dive deeper into topics such as why Dr. Saema decided to leave the medical establishment and open her own boutique-style practice, how her diagnostic process differs from that of the traditional medical approach, the lack of education in sleep medicine occurring in med schools and residencies, how dental providers can detect sleep and breathing issues in their patients, the challenges with traditional polysomnography in detecting airway issues, especially in children, the numerous comorbidities of pediatric sleep-related breathing disorders that all dental and medical providers must be aware of, and other sleep-related topics such as the impact of hormones on sleep, how much sleep we actually need, and even strategies for getting better quality sleep. This is really a fascinating conversation about all topics related to sleep, and it's with a quadruple board certified physician. I ask her the questions a lot of us in the dental community ask one another and may not always know the answers to. So it was a pleasure to sit down with an expert in this field to answer many of those questions and be able to bring you, my audience, those very answers. If you know anybody who could benefit from hearing this information, even outside of the medical community, friends, family members, please share this episode with them. As the more we can get this message out, the more we can help everybody live a happier, healthier life. So without further ado, let's get on to today's episode with Dr. Sima Tahir. Enjoy the show, everybody. Welcome to Doc Podcast, Saema.
Hi, how are you?
Doing great, thank you. Thank you so much for coming on. A little shout out to Luke Shapiro. He connected us, so I always appreciate it when people put me in touch with great people to be able to meet and have on the show. So I know you have a super busy schedule, and I really appreciate you taking the time to come on and speak with me and speak to the audience about what you're doing and what you've done in your medical career, but especially as it pertains to sleep and sleep medicine. If you could, just start out and tell the audience a little bit about who you are and where you came from to get to the point that you are in your career today.
So by professional background, I'm boarded in way too many things probably, but I am an internal medicine doctor, but I'm quadruple boarded. So internal medicine, pulmonary disease, critical care medicine, and then sleep medicine. And I graduated from a pulmonary and critical care fellowship in 2019. And about not a full year later, March of 2020, something huge happened in the world. Mm-hmm. So initially, one of my first jobs, I was doing some bronchoscopy by background, but then the COVID pandemic hit. And I, for almost 2 years, was working every single day in a COVID ICU, days, nights, all over the place, whatever was needed, I was filling in. And I loved it. It was a little bit tough emotionally, physically, et cetera, but it was an interesting time, to say the least. Mm-hmm. And about 2 years into the pandemic, when things were kind of slowing down, and I hadn't really been doing everything I was trained to do. I hadn't done much pulmonary outside of managing ventilator and sick, dying patients in COVID, and a lot of sleep medicine. I wasn't doing any of that. And what I noticed is a lot of changes in my personal life. Some plans, some not. I had 2 kids during that time. My husband and I settled down in New York City where we decided to stay for good. And I was working a lot of nights, a lot of nights in COVID times. I was just trying to fill in any time that I could, any shift that was needed, and my body really broke down. I know all this too. Now take in mind, I am a board certified sleep physician that worked nights just to help out. And I noticed changes. It wasn't just the hormonal changes in pregnancy. It was my body really responding to what we know happens when you work nights and are not resting your body the way it's supposed to, the way it's meant to rest. So it was around the third year, I want to say third wave, when I had both my kids and I really wanted to get back to the crux of what I really loved, which is pulmonary disease and sleep medicine. And at this point, sleep medicine kind of overtook my desire to do pulmonary because I was living proof of what happens when you do not sleep and when you're managing too much and you're juggling too much and you're trying to fill so many roles, and then you are sacrificing the one thing that I tell everyone they should never sacrifice, and that is sleep. So I had the idea of starting a practice because I saw there was many holes in medicine, even as amongst my pulmonary team, amongst my critical care team, amongst other doctors. We know what sleep does to you, but I really wanted to fill a void that there was in medicine and where I lived in New York City. So I opened my own practice last fall, and it's been doing quite well. And I'm learning a lot about the lack of emphasis in sleep in the medical world, in our patients, amongst ourselves, and even myself. When we do not prioritize enough. And that's my main goal with this practice. I love to see some pulmonary disorders. I see both, but the sleep is really what I'm doing for the most part. And I'm absolutely loving it. There's a lot of holes that I'm sure we'll get into, a lot of problems, a lot of lack of insight, a lot of lack of information, emphasis, a lot. So that's where I am now. And I absolutely love it.
That's awesome. Well, first off, thank you for being on the front lines. Looking back, now 5-ish years removed, it was a scary time for everybody. I guess I'm coming up on 6 years, my goodness, removed. And it was a scary time for everybody. So the fact that you put yourself in harm's way, literally, because we didn't know in the beginning what we were dealing with. And we didn't know we look back and we think, well, our minds kind of protect us against some of those things. But at that time, it was a scary time for everybody. So thank you for doing that and sacrificing your health and wellness to be able to do that. It's interesting too. I love how, and I say this so often, there's so many times that those challenges are those times in our lives where we're pushed beyond our limits, or we find ourselves acting in ways that we probably know better, are some of the times that we learn the most from. And at least it's an opportunity to, and kudos to you, you did. I don't think we always learn from it. You learn from it and you notice, wait a minute, I'm not walking the walk, so to speak, here. And that puts you on this journey and path that you're on now. And now just think of how many patients you're helping every day with what you do in the capacity that you are. So in that, when you made the decision to, I don't want to say stray from, but distance yourself or go in a different direction from the kind of traditional medical system and go into your own private practice, talk about that a little bit. How did you, that's about a year-ish ago, and how did that come to be? What was your thought process when you decided to do that?
To be honest, a little bit background of sleep medicine is needed here because you can do a sleep fellowship from multiple avenues. You can be an internal medicine physician, a pulmonologist, I think family medicine, psych, neuro. There's different realms you can do it from. And that's great because sleep is not one dimensional. And there's possibly many things that are contributing sleep disorders in the majority of people. But there's a lot of harm in that too. If you're not willing to work together and really think about all different possibilities that are contributing to sleep problem, you really may only be thinking at it from your narrow niche. Like as a pulmonologist, am I only focusing on sleep disorder breathing? As a neurologist, am I focusing on the movement disorder, psychiatry, insomnia, et cetera, et cetera? They're all multifactorial, okay? If you think about it in that way. So when I started doing some more outpatient pulmonary work, and I took this job as I was trying to transition as just pulmonary and sleep, and I was seeing a lot of patients, I was like the last person they were coming to. They had seen the neurologist who said, well, you don't have a movement disorder. I've seen the psychiatrist. Well, you don't have trauma, blah, blah, blah. Now, I'm not speaking for all physicians who treat sleep, but this is what I was seeing. And I felt like there was so many limitations in practicing sleep medicine in a facility or hospital, I must say, that is pulling you in many different ways and not understanding that sleep, the history of sleep is not something that you can do within a few minute visit. And it really takes a lot of work with the other providers involved in the care. So in my opinion, I felt like the only way to provide true sleep medicine, I hate to say this, was to start my own practice. And I'll tell you this, and I think we've spoken about this before. For me to take a pulmonary history, it takes about, let me say 15 to 20 minutes. I'd probably be being a little quick on that. But in a sleep history, I need an hour to take a history in sleep medicine to truly go through and see which sleep disorder is present. It's not just the sleep apnea, insomnia, hypersomnia. There's about 100 sleep disorders that we know of. Wow. And there's just not, the way the hospital is structured and run, it's not possible to do that. Now, after I take a sleep history, I'm on the phone if there's a neurologist, with the primary care, with the psychiatrist, with the dentist, with the orthodontist, with the oral surgeon. And that needs to be done for every patient if they are involved in this type of care, and it's very hard, unfortunately, and it's very sad in a hospital system right now to do what I want to do for my patients in terms of sleep. It is just not set up for that. There's not a lot of resources. And, if I'm seeing the sleep aspect, but I really need the neurologist to weigh in on what he thinks about from his or her specialty in terms of sleep, not everyone in a hospital does neuro sleep, psych sleep, Yeah. So it just becomes me without anyone really wanting to communicate as well as I'd like them to be. So it takes a team. Sleep really takes a team. Mm-hmm. Communication amongst different providers is so much of what I do and so necessary.
I love that sleep takes a team. And it's the same thing we struggle with in dentistry because, and especially orthodontics, and I say this all the time, having been a busy practicing orthodontist for almost 20 years, it doesn't fit within our paradigm. We have this system. It doesn't fit within our smoothly operating machine that is our practice. And that is a lot of what happens, like you were just describing, in the traditional medical system and hospital-based care. They have to run on certain time blocks. Mm-hmm. And we call it in medicine, correct me if I'm wrong, but it's more enforced from above. We tend to enforce it on ourselves. We have a lot of consultants and people who help us get hyper efficient. And I'm not pointing fingers. I did the same thing in my own practice. But that kind of pigeonholes us into this limited time in our diagnostics. And I often say one of the reasons a lot of orthodontists don't want to go down this sleep journey, because we will talk about today the fact that it's really hard to ignore once you understand what it is and how pervasive it is. Yes. A lot of the ones that don't want to go down that path, they just don't want to change their practice. They don't want to change their business model. They don't want to change how much time it takes to do exactly what you just said. And it's not that we're not the sleep physician, so we're not taking an hour solely on sleep. That being said, we have to totally revamp our intake process, and then the communication with our medical colleagues and other dental colleagues, myofunctional therapy teams afterwards is so onerous. And when I did all of that, it took me a lot of time and energy to build those systems and train my team. And so there's just a lot of moving pieces to it. So I'm so happy that you had said that.
Yeah, it's difficult. It's possible, though. Like if you really care, like what you mentioned, once you get into the sleep realm, once you recognize it, whether in yourself or when in a textbook or listening to podcasts or watching something, you can't get it out of your head because sleep really dictates everything we do, the way we act, the way we think, the way we are in every aspect. So, yeah, it's been good. I'm happy. I'm disappointed that there's not as many of me out there as I'd like there to be, because the need for sleep is huge. Yeah. I'm hopeful still in my heart that one day the hospital systems will catch up. But these days we're assembly line workers, and redoing that infrastructure is very difficult. But I have hope, because unless we prioritize sleep, we're never going to be able to fix so many other medical problems. And that's what I wish people would recognize.
I agree. From your standpoint, why do you think so, and we can kind of talk about it on the orthodontic side and dental side in a second, but from the medical standpoint, why do you feel like there is not more education? Or I guess maybe first, how much education really is there from someone who went through this process not that long ago? How much education is the average physician, standard physician through medical school, and then in, let's say, a non-sleep-based type of postdoc training? What's the education look like in the medical arena?
Yeah. So sleep is sprinkled in your residency, depending on what avenue you do it through. I'm internal medicine. So before I do specialties, I do 3 years of internal medicine residency. So if it's not emphasized in internal medicine, it's probably not emphasized as much elsewhere, maybe in psych neuro. It's a sprinkle. It's taught like this. You need to tell your patients to eat well, sleep well, work out, good diet, good exercise. But what do those things actually really mean? What do they mean? And in what way are they going to have an effect on other medical problems they're coming to see you for? Or how are these, if not followed properly or not addressed, are going to be risk factors for other medical problems, right? And it's a sprinkle. It's just mentioned. In my internal medicine residency, in my medical school training, I never learned about sleep. I know it's a thing because I do it. And I know that we're supposed to have good lifestyles, right? Or have healthy habits. Now, in my sleep fellowship is 1 year. Again, you can do from different specialties. I loved where I did my sleep fellowship. I did at Temple. I had some great attendings who love sleep just as much as I do, and they're phenomenal. There is a lot of emphasis on sleep disorder breathing because at the time I was doing my fellowship, there was a lot of cardiac risk factors associated with untreated sleep apnea. But we did dabble. I rotated with a pediatric neurologist to do my peds rotation. So I got a whole different realm, something completely different, a different set of eyes and ears as to how you should approach kids. And then from a neurological perspective, somewhat. Now, we did do a little bit of insomnia, which is the biggest sleep disorder out there. We did a little bit of hypersomnia, it's your narcolepsy or idiopathic hypersomnia, but I had to really, really learn a lot of that myself when I was studying for my sleep boards. So I had to really pull the books, listen to the videos, take some courses, et cetera, because I knew the gist of it, but I didn't really understand it. I really need to understand things to be able to take the board questions and to understand my patients. Yep. It's not just, well, this, you can't sleep, so it's X or Y or Z. It's, well, why can't you sleep? Is it potentially X because of all of these other things? Is it Y because these don't fit? You know, it's very, very different than even just reading a CAT scan of lung disease and just saying, oh, this is this, and that. It's very, very different.
Yep.
So there was emphasis because I did a sleep medicine fellowship, but how much was really accounting for all sleep disorders? Not as much as I'd like, but it gave me a good foundation. I happen to absolutely love sleep. I'm probably obsessed with it. I think it's probably the most important thing that we should prioritize. One of the most important things we should prioritize in medicine. And after I took my boards and did fine, I did great, but I kept learning because there was so many holes in the system. I had to go to different resources. There's not a lot of robust literature in sleep. So the Academy of Sleep Medicine has a forum every morning, which is phenomenal, that we can run interesting cases by, see if there's any case report stuff. And that's something that I utilize a lot because I find it so helpful to have such a community dedicated to wanting the best for patients when there isn't a lot of robust support from the medical world. We really rely on each other. But in terms of answering your question, unless you see the details out yourself of sleep, I'm going to be very honest. People may hate me, but it is not there. It is not emphasized. It is not presented. It's not discussed. If you're a cardiologist and you know that sleep apnea increases your risk of heart disease and arrhythmias, do you have a course you can attend? Do you have talks about that? No, it's just thrown in there in the talk of atrial fibrillation as a 1 or 2 liner. It's not really taught in the detail needs to for you to understand how big of a role it plays. It's just mentioned. And then we get into like the insomnia and hypersomnias and movement and parasomnia is a whole different world. And it's like people don't even want to touch that because now it's something completely different than what they do. It's like this whole entity in itself, like, wait a minute. This is something totally different. So that's never even mentioned. We've heard of sleep talking, sleepwalking, that's about it. Narcolepsy falling to the grounds, but the details of it, many people don't know. Many physicians who are aware that these exist don't know where to start in opening that kind of worms from.
Wow. Is it fair to say that the pediatricians are getting little to no training in recognition of sleep disordered breathing in children?
I can't speak for the pediatricians. I will know that I know that I've met some that are very, very, very cognizant of where there may be a sleep disorder hidden when parents are bringing their children in for daytime complaints or nighttime complaints.
Okay,
and then
great.
That are not.
Yep.
That's the same with pediatrics and adult doctors. It's the same thing. It's, again, the ones that are very in tune to, potentially, is this ADD or ADHD or is it undiagnosed sleep disorder? I think that they really prioritize sleep themselves and they're very, very passionate about or interested in it. And it's a 50-50, maybe even a little bit. I wouldn't even say it's 50-50. There's more people that maybe know a little bit, but want to check the labs, want to make sure there's some other diagnosis they're more familiar and more comfortable with, and then the sleep gets addressed later on. I will say that they're potentially, by the time someone sees me for something I think has been there for years, I'm like their 5th or 6th doctor. Yeah. So there is a little bit of delay, but when people are aware of it, they're very aware. And I honestly appreciate them. Adult doctors, pediatric doctors, they choose to really seek out the information themselves. I meet with doctors all the time just to run cases by, to present cases, to see this is where you should be thinking about sleep. And that's strictly because I need to start someplace. We need something. And I'm happy to provide that,
Yeah. Yeah, it's so interesting because we don't get training in dental school or in our orthodontic residencies. And I find it really fascinating to see the parallels. And here's this thing we do, hopefully, a third of our lives, right? Sleep. And maybe because it's a passive process, we're not just like conscious while we're doing it. So we just think, yeah, all sleep is the same. Or if I'm in bed for X hours, there's no real rules on it. And we don't, to me, it's kind of that frog in the boiling water. It's a slow process when we go through it as adults, at least speaking. Like it's like any chronic disease. It doesn't, if it hits us hard, like something, say I had the misfortune of, for 20 years, I hadn't been hit with a stomach bug, and I got hit with one recently. And I mean, it comes on like out of nowhere, right? And something is wrong with you very, very quickly. The sleep realm, a lot of times it's gradual. And so I notice in parents, they would just be like, well, I just thought they were just kind of a anxious kid, or I just thought they were a restless sleeper, right? They've always thrashed around the bed. I just thought that's how Johnny was. Yeah. So that's one of the obstacles, I think, is it's not readily apparent to a lot of people, the parents themselves. So we get none of that training. And what's frustrating to me, and I want to hear your thoughts on this, we get told by the American Dental Association, the American Association of Orthodontists, the American Association of Pediatric Dentistry, that we should screen all patients for, they call it obstructive sleep apnea, but we can go on. I know, we know that's the end stage disease. It's a little, I'm big on screening for the signs and symptoms of sleep disordered breathing, of which obstructive sleep apnea is obviously the most severe form. But they say that, and I like that they all say that, but no one teaches us how to do it. Like I just had this conversation with a colleague last week. He was at a big meeting the ADA, American Dental Association, is holding to try to start to figure this out a little bit more and help us quantify how to look at these patients in our practices. But no one really knows. So because we don't get any education, we kind of go off of the little knowledge that we have, which is dangerous because that Dunning-Kruger curve, right? We're at the peak confidence. We're these smart specialists or doctors, and yet we have minimal knowledge. So we kind of find ourselves in that peak ignorance. What are some of the things that you could pass along to any colleagues, whether it be dental or medical, because I've both that listen to the show, and laypersons that listen to the show? What are some of the warning signs? We'll start with the kids and then go to the adults. Some of the things that you see routinely in practice, and I know we could spend 2 hours just on this, but just some of the kind of the elevator pitch things. Like if this is happening to you or your child, you should be thinking there may be an underlying sleep issue here.
Yeah, great. I appreciate that. And I'm not going to just focus on sleep apnea because a lot of sleep complaints overlap, but signs and symptoms concerning for some type of sleep disorder. And we can almost start head to toe. And I always break this apart into night and day, okay? Because sleep disorders manifest as nighttime problems, but more so sometimes, especially in kids, as daytime problems. So headaches, blurry vision, jaw pain, neck pain, teeth grinding, jaw clenching, tension in the neck and traps or upper body is a big one. And then your nighttime cough, your choking, your gasping, your nasal congestion in the morning. Those are really, really big ones. If you're having trouble falling asleep, staying asleep, or you're waking up really early in the morning. If you're unable to fall asleep within 20 minutes, if you're falling asleep within 10 minutes, there's so many. I'm going to keep going. If you're waking up feeling unrefreshed, no matter how many hours you slept, and too much sleep is bad. But if you're sleeping that, what we're told, 7-8 hours, and you're still feeling unrefreshed, that should be a huge sign. If you're waking up with headaches in the morning, a big one as well. If you're kicking and screaming and acting out, that's another one. That's a huge concern for kids and adults, surprisingly. And then during the day, I try to emphasize this more so. Despite sleeping enough hours, are you still tired? Are you waking up unrefreshed? Are you having brain fog? Is it taking you a little bit to come into your senses in the morning? Do you have irritability in the morning? It's not just sleepiness. Are you like taking naps or dozing off? Are you having memory problems, mood difficulties, word difficulties, irritability? Mood is a huge one, especially as we get older in life and we're like, oh, I'm getting old. I'm having trouble remembering things. It just doesn't happen overnight, but in general, last week you were fine. This month you were fine. You're not quite really that old, it's a very subjective age as well, but things just are not coming to you as they used to be. You're still working, you're still able to go through the motions of the day, do excel in your job, but it's just difficult, or you're having more irritability and mood fluctuations. In terms of children's a whole different ballgame. It's hard to get history out of children. It's challenging, and parents are not very successful either, despite being the best parents and trying hard. Kids are just not as forthcoming because they can't recognize it as easily.
Right.
But ask your child about the questions, all the headaches, the jaw pain, the teeth grinding, nightmares is a big one. If they're having any uncomfortable sensation in their legs and arms. But during the day, getting a history from the family, the friends, and the teachers is very important for children. Are they keeping up with the tasks in school with the other kids? Are they able to keep up with the other kids in terms of social listening? Are they having challenges in remembering different tasks that you've taught them? Or the other one, are they having attention hyperactivity and focusing problems? Traditionally we think of ADD, ADHD, but undiagnosed sleep disorders. The symptoms of an undiagnosed sleep disorder manifest very similarly as ADHD, ADD, and other psychiatric illnesses in kids. Huge difference in management, though. Huge. Big delay in treatment, right? So pay attention to how they are during the day. Do they just look like they're dragging throughout the day? Was your teenager playing basketball for the past couple of years and now he just doesn't want to? Don't assume it's just him being a teenager, It is a lot. Again, that's why I say nighttime and daytime. And we can go even deeper. The review of systems page when you go to the doctor's office and they're like, are you having cough, any chest pain, any trouble breathing? That whole thing that you're supposed to check off. As a physician, every check mark on a box that's positive for that symptom can potentially be traced back to something in sleep a lot of the time. So, but we're never asked about sleep in that review of systems.
Right.
So physicians, and even for parents and patients themselves, adults, kids, anything that seems different or unique, I almost feel like we should delve into sleep. In some way. I'm a little biased. But
at least rule it out, right?
At least rule it out. There's no harm because there's a big delay already in treatment. Now you're looking at years down the line. And sleep disorder, if you're not getting good quality of sleep, forget hours. Quality is actually more important than hours. You will feel the repercussions of it later, whether it be just from mood, memory, functioning, but also in terms of health consequences, heart, lung, thyroid, etc. All of these things can be traced back to some poor sleep. So being aware of it and how it can affect the body is challenging, but easy also. Anything that seems off, anything that seems like it doesn't fit, anything new, sleep should be investigated. And I think every physician, every provider, everyone who is involved in the health of a patient or a person should be thinking sleep all the time. Because if you're not thinking it, you will miss it. If you're not thinking it, you're going to find some other reason to go down an avenue that may not apply. So it should be in the forefront of our brain.
Yeah. Thank you so much for laying that out. That's a really great summary. And the fact that it is so comprehensive only speaks further to the fact that this is such a major underlying etiology in so many of the comorbidities that we're seeing in our patients all the time. And as dentists, yes, a lot of the pediatricians are part of a medical system where they can't spend time with your child. Having had children that are now in their mid to late teens, I mean, when they were younger, we were just talking about this not long ago, they actually got some FaceTime with the pediatrician and we got, knew her and there was more direct interaction. As they got older, it just became the PA almost all the time. The doc would stop in, maybe give a little greeting, how you doing, look real quick, check through the main parameters that the PA had screened for, and then she's gone. And so the onus tends to fall on the dentist more frequently, I feel, because I saw so many kids, Saema, who were like, the parents are in tears in my consult room because let's say the child was 7 or 8 years old and I start looking at their 3D image and looking through their clinical signs and seeing the dark circles under their eyes and the chapped lips and the open mouth posture and the transverse deficiencies and looking at their CBCT and seeing turbinate hypertrophy and or lymphoid tissue hypertrophy or whatever it is. So asking them the sleep related behavior questions, and you see the parents literally, some of the moms, tears in their eyes. And they're like, well, first off, we came here for teeth. Like, how are you know this? And I would just ask more questions about their sleep or their sleeping pattern and their breathing. And then when you tell them this, can you see that they have ADHD and maybe they're on a medication for that and they're getting extra help in school or whatever it is. Now, people think as the orthodontist, I'm there to straighten teeth. What am I doing? It's because I'm there to treat the whole patient. And when I detect this, it can be directly related to the craniofacial growth and development, which is my direct responsibility. That being said, I can detect these things pretty easily once you see it and know what you're looking for. And while it's not my place to be the one to treat it or formally diagnose it, when you ask the parents, they literally I've had parents in tears and say, why are you the first one to bring this up to me? You're telling me that it was related to my child's sleep and we could have done something about this all along. Or they'll say, I knew it. I knew that they weren't slow or remedial in their learning. I knew, they were super smart initially. And then all of a sudden they struggled to keep up in school. And so that to me is part of my why, my mission, and why I want to see more education on this and more of my colleagues to start to recognize this in their patients. And I want to speak to that for a second, because that gets controversial in my world. In the dental world, and I'm not sure how much of this but just to preface it for anyone else listening to who isn't aware of this, but in the dental world, especially the orthodontic arena, this whole topic of sleep and airway is very, very controversial. Goes beyond the scope of the day to talk about my thoughts on why. It just is. And so it's oftentimes a lot of colleagues mock it. They talk about the fact that, expansion doesn't have any impact on airway, or we don't have any place looking at airway. And another thing you touched on that I want to underline, and I always say this, is that the etiology is multifactorial. So the solution needs to be multifaceted and oftentimes multidisciplinary. Mm-hmm. And that's really overwhelming for most dental providers to think about. So it's just kind of easier to keep your head down. You're not like you're doing harm to these patients when you just straighten their teeth necessarily. Right? You're still making a nice smile. Or if you're just a pediatric dentist and just doing fillings on all this decay, which may be related to the fact that they're a chronic mouth breather and have xerostomia, but it's just kind of easier to fix it. What would be your advice to the dental colleagues who are skeptical of this and don't think that this is like a thing that we should have in our arena?
Well, we all need a team, and we all sign up to do what we love in the hopes of helping a patient. And sometimes that means outside of what we're not used to doing, but we should be aware of it. So I appreciate all the dentists and orthodontists who are screening for the sleep disordered breathing or the sleep disorders per se. It is easier to just do the algorithm because you're good at it. You know how to do it. The family gets an answer. The patient gets an answer. You have something to provide. But there's no harm in educating people about where the problem may reside. Mm-hmm. We all want to just help our patients. That's all we want to do. And sometimes that means they may not need to come back to us, or that they may be better served elsewhere. But isn't that what we sign up to do this for?
Right.
That's the way we need to think about it. It is an honor and a privilege to do what we do, from your realm, from my realm, and to do it not just limited to what we know, but to really put the patient as a priority from head to toe is how we can be the best type of provider. Truly. Yeah. There are many people that get sent to me, and I really, especially children, I don't think that suppose they have sleep apnea for tonsils or adenoid enlargement. I send them to ENT. They're not going to come back to me, but I diagnose the sleep disorder, or I see someone who has, I had a patient the other day that was sent to me from an orthodontist for really, really bad jaw clenching. And I have the sleep study. I can't really help them much outside of that. I read the sleep study, but I sent them back, and I sent them to someone else who could potentially help them for TMJ, et cetera. But I think that we need to stop looking at it as uncomfortable. This is to be the opposite. This is how we're making our patients comfortable with their bodies and their health, is by addressing everything that we are aware of, that we should not be withholding information if we know can benefit one of our patients. Isn't this why we do what we do?
Yeah.
And that's what we need to remember. And yes, there are some patients who come to us and they want an answer just from us. They don't want us stepping outside of our zone. And that is a phenotype of personality. We're going to get all of those, but all we can do is still do what we're supposed to do. And that is to care for our patients from every aspect that we are in tune to and we're aware of. That's truly how I do my job. And I wish that everyone did. And I hope that everyone does, So
I love that.
It's the best for the patient. How can we best serve our patients? Learning more, exploring things, thinking about things that are not so common and from our realm and our domain that potentially can be an etiology. If you're not 100% sure about a diagnosis, we shouldn't be making one either. And there's no problem in phoning a friend or recommending a consult or et cetera. That's how we get our patients the best care.
I completely agree. I love that. And so well stated. On the note of polysomnography, sleep studies, that is one thing that, again, we learned none of this in our schooling. So I thought for a while, AHI in kids is the barometer of disease, right? That's it. If they send them for a sleep study and they have an AHI of 0, they're fine. And when I lecture, I actually talk a lot about that. And I've had guests on the show in the medical arena that have set me straight and helped me learn the difference in that over my journey in the past number of years here. what would be your advice to colleagues, medical or dental, on some of the challenges with polysomnography, especially in children, but I know even adults with upper air resistance syndrome and can miss things. So talk a little bit about that, if you would, in terms of the testing. Like, so we detect maybe a patient might be suffering from some of these issues. And I think what the default is for a lot of my dental colleagues is send them for a sleep study. And there are obviously logistical issues to that, practicality issues to that, and validity issues to that. So if you could just speak to those for a moment, that'd be great.
So sleep studies, whether they're in-lab sleep studies or home sleep studies, are not meant to rule in or out all sleep disorders. They're meant to help diagnose sleep disorder breathing, and to what you mentioned, upper air resistance syndrome, a little bit more difficult. But that's what it's really used to diagnosed. That is one of many sleep disorders. So a normal AHI does not rule out sleep disorder breathing. We use the RDI in the Academy of Sleep, first of all, which a lot of people are not aware of, which is why it's so important to look at all the graphs. When I have someone ask me a question about a sleep study, I need to look at the graphs. I truly do. I need to look at the position, the stage in sleep, what's happening in certain parameters. Some sleep studies that are home sleep studies do not give you all that data. Many do. In-lab sleep studies give you more data. In-lab sleep studies can help with some movement disorders, and they can help with potentially some parasomnias. But I think the big picture is that a normal sleep study does not rule out the possibility of a sleep disorder. They really are meant for sleep disorder breathing for the most part, and then maybe some movement. But if that's normal and the patient is still feeling unrefreshed, still tired, still dozing off, still having the attention memory problems, that doesn't mean that there's no sleep disorder present. I get a lot of patients ask me, I need a sleep study, I need a sleep study. Well, hey, not every sleep disorder needs a sleep study, okay? And then I have many people who've had 3 normal sleep studies, and I told that there's nothing wrong. So I'm not sure, they just wanted me to come here and blah, blah, blah. And I review the data, I get the history. Well, a sleep study was never warranted. Of course it's normal, because this is not how you diagnose this sleep disorder, or this is a correct sleep study to diagnose this sleep disorder. In-lab sleep studies come in various forms. You have the one you sleep overnight, then you sleep overnight, and then you stay the next day for naps, which is an MSLT. So if you had just the overnight portion, you may be missing a lot of sleep disorders. So I think that sleep studies should be given for certain things only, and not every sleep problem. But if you come back, you get the results of a sleep study and it doesn't fit, meaning, well, how can they be feeling all this? They have all these complaints. AHI is normal. Even RDI, let's say, is normal. Don't think sleep. This may not be the right test for them. Still think sleep.
Okay. That's helpful. And in children, I know, especially, I've told the story many times, but a patient who was 6 years old, and we'll have the patient take a video a lot of times of the mom take a video of the patient, or if they have an old baby monitor or something around, or still have some young ones at home, set that up so they can see the patient sleeping, because oftentimes parents they aren't aware. They literally aren't aware. A lot of times people will say, like, oh, well, we traveled and went to a hotel together, and that's when we realized it, when no one wanted to share the room, or we all were up all night because so-and-so was snoring. We didn't really know they had that problem. So we'll have them videotape it. And I've had instances where the kids are literally suffocating in their sleep, and they go for polysomnography, and it comes back as 0 from the AHI, and the parents will come back and say, the ENT said he's fine, there's nothing to do, we don't have to look at anything any further. That's really hard for us in the dental community, because it puts us in a position where we've taken this time, we've gone over this. So what would be some of your advice to this? I'm speaking specifically to the dental colleagues or the parents, because of the parents who listen. I know many of them have had this happen. What do we do when that happens?
So that's a challenging one, because you have all these subjective complaints and the objective data doesn't match up. But there's a few different things. The objective data may not match up because there is an entity called primary snoring as well. And there's sleep apnea. They can exist together. They can exist without each other. So I still want to emphasize that, yes, choking and grunting all night and then the sleep study is normal doesn't rule out a sleep disorder. So you should still be wondering if there's one present, if, again, patient, the kid or even the adult maybe is waking up unrefreshed, is tired throughout the day, not keeping up with their age kids or adults, whatever it may be. If they seem like they're overly sleepy. And in kids sometimes, are they not eating? Are they overly hyperactive? Do they seem like they're just completely overstimulated throughout the day? So if those are still present, Then I would go and review. To what I have to do, this may be different than what you guys can do, is I review the raw data. I review the sleep study. I actually see when that episode is happening, and I march down what's happening in the thorax and the limbs and in the breathing pattern, and how, if there's oxygen dipping, if not, is there just abnormal effort, is there loud snoring? And taking that history and then applying it to that area of the sleep study is very important, because you usually can find something. And you have to remember that AHI is an average per hour. Right? So if you do a sleep study and the patient is, suppose only apneas or abnormal breathing was noted when they were on their back and only in REM, which is an entity in itself, but that sleep study didn't catch the child or the adult on their back for long enough or in enough REM sleep or whatever it may be, you're not going to see sleep apnea because it's an average per hour. So if you're lessening the REM and lessening the time on the back, it's not going to have an AHI then or an RDI that necessarily meets criteria for sleep apnea. But when we review the raw data, and there does tend to have abnormal breathing when that episode happened, we just didn't catch it with enough data on the sleep study. So it can be the presence of sleep disorder breathing. And I'm seeing this actually very often. And you have to remember that position, not so much, but stages of sleep are influenced by a lot of different things, by medication, by environment, by stress, by illness, et cetera, et cetera. So you may not have captured enough of that sleep stage where there was abnormal breathing happening on the sleep study because of multiple factors that influence REM sleep or NREM sleep, which is another common one. So the raw data really helps in reviewing that for me. And that's not so much easier for people who don't read sleep studies, but I do find, actually I had one this morning, similarly, everything was normal, everything's normal. I pulled up actually the graphs, and there's sleep apnea present severely on the back during REM.
And in this particular case with this patient, as I asked mom some more questions about what happened, she told me that they stopped the test at 4:30 a.m.
There you go. So they didn't really have...
He never got deep enough into REM. Yeah, so he probably never had an episode. Or, I mean, who knows? Maybe his episodes weren't 10 seconds or 2 successive restoration. I mean, there's just so many variables. And so those create some challenges. And I encourage my colleagues that doesn't mean you still don't do what you can do to normalize anatomy and help what we can help, right? I mean, like if I know that the patient, okay, great. So they don't have an AHI of 1 or greater. Fine. That doesn't mean that if they're narrow and they have a transverse deficiency and insufficient tongue space and a high vaulted palate and turbinate hypertrophy, I'm still going to go in and try to expand and develop the arches. I'm going to send them to the pediatric allergist to see why they have this swelling and obstruction in their nasal passageways. So,
and I think also, not to interrupt you, but from your background, this is what I actually love, because your treatments can really help multiple things, multiple problems the patient may have or that you foresee happening in the near future anatomically. And the sleep is just icing on the cake. It just can only help. It's not going to necessarily worsen things, hopefully, but it's really nice that you're able to do that, because you can recognize things that may be involved with what you're seeing anatomically and potentially fix all of that, which is amazing. And you're not pulling it apart, So that's something I've been very impressed with from the dentistry and orthodontics world. Because then I learned a lot from my patients. Well, I had this problem. Then I call up the dentist or orthodontist, and I'm like, why did you send them for sleep evaluation? Well, based off of what I'm seeing or what I see in a child in the next 10 years, this is probably what's going to happen. And this treatment or this intervention now will prevent all of this. And I love it. When we truly practice sleep as preventative medicine, which it really should be, phenomenal. Gold mine. It's amazing. It's so much. It's the missing piece of the puzzle.
Yeah, it's so true. It's so true. And that's why I'm so addicted to it and I'm so passionate about it, because I saw what it did for my patients. And creating beautiful smiles and straightening teeth is awesome. And I loved that part of orthodontics because I didn't always think this way and know what I know now about sleep and have a sleep focus at all. I mean, I wasn't trained in it in the first probably half of my career. Even though I was always trying to help grow instead of restrict and constrict the face, I was always trying to avoid extracting teeth just intuitively. It wasn't for airway reasons or because of sleep. I had no clue. It was as more and more parents started telling me what they were seeing happen to their children as I was doing these things. And then I'm looking at my pre and post treatment records, which I encourage everybody to always do. And I'm seeing patterns in these patients that I helped. And I'm seeing changes in their neck posture, in their pharyngeal airway, in their tongue posture, in their behavior, in their eyes. Beforehand, they've got these tired eyes with dark circles under them. And afterwards, they've got these bright eyes like a 7-8-year-old kid should have. And and it kind of led on this journey. And then the parents are saying, geez, Dr. Mike, you think they're behaving better in school? They seem to coordinate with what you're doing. Do you think there's any relationship here? So as you said, it should be the kind of the undercurrent of all of this is sleep and airway. And we're just looking over it because we're focused on the symptom of that, which is the malocclusion and the aberrant growth, craniofacial growth and development in our world. And we can just chalk that up to genetics, which unfortunately a lot of people in my field still like to do. Well, it's just genetics. Well, yes, there's obviously a genetic component. That being said, the epigenetic component and the environmental component and how that is affecting and impacting the growth and development, not just craniofacial growth and development, but neurocognitive and behavioral growth and development. It's just such a shame to me that more of my colleagues don't embrace that concept, but that's why I'm on this mission, and that's why I'm talking to you.
Sleep has become more of a popular topic because you have the Atlantic, the New York Times, you have the Wall Street Journal publishing all these articles about it, and more jobs are requiring wellness talks where they are sprinkling in some sleep. So I like that. But I think in the medical world, in the dental world, we need still more people who know more about this, to really, really think about it with all of our patients. If you're not thinking about it, you will miss it.
Yes, that's the reality. That's exactly it. And on that note, one of the things in adults is hormones. And you talked a little bit about that in the beginning, and the hormonal changes, especially perimenopausal, but even with men, hormones change as we age. My primary care, I mean, nice guy, but I just went last week, and it's like, how you doing? Good? Feel good? Sleeping good? Bowels normal? Like, it's like that's it. It's stethoscope to my back, my chest, my back. Okay, great. I mean, literally. And I'm thinking, and I happen to have chronic allergies, so I see the allergist, immunologist for immunotherapy, and and he's just like, oh, you're all good with that, yeah. I mean, there's so little. He never asked me any in-depth questions about my overall health and well-being, and I know that's the case with most people's primary care docs. Why is it not more commonplace for physicians, especially as patients, kind of step away from the kids into the adults, especially as adults are aging, and we know the impact that our hormones have on our sleep cycles? Why isn't it a bigger focus? And can we at least be somewhat optimistic that maybe it's going to get there where we start to ask these questions proactively instead of letting patients suffer and just say, oh, well, you're getting older. That's normal.
Yeah, I hate when it's this is just part of being a woman, just being aware of getting older. Man, this is just how it is, You're working too much or whatever, whatever.
I've seen way worse than you. You should be thankful you're not worse. You're like, what? What is that?
So insulting too, because in many ways, sure, that's easy to say, but we're also the people who should be asking the questions, they're just, sure. Some people aren't even in tune to things, I think there's multiple layers to this. There is a lack of education. There's a lack of knowledge in terms of sleep. Okay. There's a lack of wanting to recognize things when you're anchoring on something else as being a possibility, age, menopause, whatever, blah, blah, blah. So if you're nearing those ages, this sleep is a common cause of sleep complaint, or menopause is a common cause of sleep complaints. Well, yes, those sort of sleep complaints, problems, diagnosis can be treated, by the way, menopause. There's a lot of anchoring on alternative diagnoses and not wanting to delve into how we can help support these symptoms, et cetera. There is also, and I'm going to call out and say this, we all function well despite sleeping poorly. Many people have gotten to very high achieving positions. They get through the day, their bills are paid. They don't emphasize sleep themselves, so they're not going to inquire or emphasize it in the health of their patient. Truly, if you were survey 100 physicians, 100 orthodontists, 100 dentists, you will find that majority of them, objectively, who are asked the sleep questions, probably have horrible sleep themselves. So if you're not going to prioritize it, you're subconsciously or consciously may not prioritize it in your patient.
Yeah.
And I think a lot of it is also the lack of sleep support. There aren't as many sleep physicians as we'd like. Again, it's a very multidisciplinary field where they don't want to be the face of not opening Pandora's box and not having a solution to this or not knowing where to go.
Yep.
But you can always call the big hospitals where they have sleep institutes, and this physicians would be helpful, I'm sure, very helpful to guide you in the right place. So there's that. And then you become what you practice, right? So the patient who comes to you with a little bit of heart palpitations and tired during the day gets diagnosed with sleep apnea. and you treat them with CPAP, but despite being compliant with their CPAP, they're still tired, they're still gaining weight, consequence of poor sleep, et cetera, all these things. You don't even think about potentially, is there another etiology going on, or is there another diagnosis in the sleep world? So you just kind of say, okay, you just continue ongoing treatment. If you prescribe a treatment or you refer for treatment and the treatment is put in place and it doesn't fix the symptoms or does not alleviate the symptoms as much as you would expect to, then we should be going down the beginning avenue, just the diagnosis from day one of diagnosis. So I think it's comfort, lack of awareness, lack of education about it. It's a little bit of a fear of, I don't want to bring this up and not have a solution to the problem because they're going to keep coming back to me now. And a part of it is like, well, it's part of life. I got through it, and no one emphasizes sleep the way they should be, but they'll be very, very, very easy to add on another medication for the uncontrolled high blood pressure, another medication for the arrhythmia, another medication for the weight loss.
Yes.
And all of that may be related to the fact that they're sleeping poorly. Are we missing the common denominator and we're just adding a new medicine? Another medicine. Medicines are great. I'm a medical doctor, but they also cause harm. Medications are a huge culprit in disturbing sleep. So if we're adding on a medication because the first treatment didn't work, or we're adding on a test, we should be wondering why. What is the common denominator we're missing? But unfortunately, we're not seeing that in practice at all. And it's disappointing because with the patients that come to see me, they're on this journey, some from the beginning with the doctor, many of them by themselves, where they had all the labs, they tried that treatment for X, Y, and Z. They tried the supplement, they tried the whatever. Despite that, they're going down their own journey. The Reddits, threads, TikTok is a great one. It's kind of opening, hate or love it. But anytime you could potentially get an answer to something that you may have in common with someone else, I love it. Because right now, if we're not doing that as providers, you need alternative ways to find out information about yourself. But disappointing. It is really disappointing. I think that the press the sleep is getting is good for just the non-medical people and as well as the medical people, because seeing it may help you be more a little bit aware and stressed out about it to see how can we implement this or think about this in our patients' plans. But it's still very much lacking. It's really unfortunate, but we're very quick as doctors to add on a new medicine or that one really bothers me. Add on a new medicine, a new supplement, keep checking labs. Well, maybe it's fine now. We'll check in a few months. It's just really unsettling because we usually are missing the one common denominator, and a lot of the time it's sleep.
Yeah.
It's never being asked about.
And correct me if I'm wrong, but sleep medicine's still a fairly new specialty in medicine. I mean, in terms of the focus on it from the literature on it and the fact that it's being talked about and published on, it didn't get a lot of press, so to speak, before, right? Versus cardiovascular disease or cancer, right? I mean, it's up and coming in that arena. And I had heard before about a guest that was on recently was talking about the lack of sleep physicians and the fact that that is a major problem. I think he was saying 100 a year. We're graduating this year was going to be 200. It was like a big year, but maybe that's that trend we need, right? Is people are becoming more aware of it, seeing it even on social media, in different mainstream publications. People can start to say, well, maybe this is, when they're in med school, they weren't thinking sleep, and maybe they don't go that route. So the more education we can have, the more discussion on it, the better. And I'm really pushing hard. It's a tall hill to climb to get the orthodontic education and the dental school education to be more proactive, incorporating sleep education and sleep disorders into the curricula, because ultimately, if the curriculum doesn't have sleep related content, we're just not going to prioritize it. It's just not going to happen. I love what you said on Pandora's Box too. That's such a great point, because I felt that in my practice when I started figuring this out, and then I'm like, oh crap, what do I do now? Oh, okay. Now I see this, I detect it. Who do I send this person to? Can I really even help this with what I'm going to do? It's a level of insecurity that when you're a competent specialist, you just don't really feel. And I was well into my career, so I really had my systems down and knew what I was doing and was really at peak competence. And I'm like, now there's this whole thing that I'm opening Pandora's box, and I'm saying to the parent, well, I guess we could try the ENT, we could try the allergist, maybe a sleep physician. I don't know. So anyway, I really, so many great points on that. If you could, kind of in the last stage of the discussion here, I'd love to spend a little bit of time talking about what good sleep is and looks like. What should we be trying to do? And I know, there are certainly extremes, but kind of that bell curve, those two standard deviation averages, we could say these are some types of sleep hygiene that you should be shooting for. And how much of it, I think a lot of people fear it's an all or nothing. If it's not every night, or if I don't get this amount of sleep every night, then there's a lot of stress on that side. So if you could just kind of paint that picture for us of what good sleep is and the difference between, you alluded to before, like just because you're in bed for 7-8 hours doesn't mean you're getting good sleep. So if we could first maybe just start talking about that.
So I would say good sleep is not defined by hours, but it's defined by quality of sleep. So hours, for the most part, we know that between 7 to 9 hours is healthy sleep. But what does that mean? There is genetic variation. There are some families genetically who need just less sleep or they need more sleep. There are circadian rhythm, genetic variability, but the 7 to 9 seems to be good in terms of hours. But if you're sleeping 7 to 9 hours, you can still be tired or still feel like you don't have good sleep because you're not getting good quality of sleep. And I always emphasize quality more so than length, because quality is something that you can't really objectively or subjectively measure, I should say. So quality of sleep is usually referring to sleep architecture. So you should be getting all stages of sleep in the correct order, spending them in the correct time for your age, and cycling through them 4 to 6 times a night. So sleep architecture. Little deviations in that, having too much deep sleep up front, having less REM, having shorter cycles of REM, will cause you to not have good quality of sleep. And you may be still sleeping that 7 to 9 hours. So it's quality over quantity of sleep. So how are some ways you can potentially maybe measure that? Are you waking up feeling refreshed? Truly, are you waking up like you had good sleep, whether that may be 5 hours or 8 hours, Are you feeling fine throughout the day? Or do you have to slam 3 cups of coffee, take a coffee break every 2 hours? Are you feeling like you can function? Are you dragging throughout the day? Are you focusing on stuff? So those things measure those measure quality more than quantity to me. Waking up feeling refreshed is a big one, and not being so sleepy throughout the day that you're dragging and need multiple cups of caffeine for. That's a huge one. That usually signifies that if you don't have that, then the quality of sleep you're getting is good.
Okay.
Now, we are very sensitive people, and I mean that in a different way than you may think. We don't do very well with sleep changes. You have to remember that everything is driven by the circadian rhythm, and our bodies are really used to having a routine because hormones are released at specific times at night, the same time every night. And hormones like to coincide with day and night activities and needs. And if you deviate from that, within 3 days, the body can become used to a new circadian rhythm or a new internal clock is another way to say the circadian rhythm, right? So I will say, enjoy your life, but if you're going to bed all weekends later, 2 to 3 hours later than you normally do, Monday morning is going to wreak hell. It's going to be horrible because what happens is as you shift that nighttime later in the next 3 nights, your sleep architecture that really is going to translate into the quality of sleep you get will change on Monday morning. And now you've cycled back. So hours are important because we know consistently getting less than 5 hours is really poor for your overall health. We know that consistently getting more than 9 hours is also poses a lot of harm to your health. Unless you're one of those genetic variants, and getting good quality of sleep. And quality really needs routine and a strict start and an end time. So much of what we do in life has been dictated by routine. Why is it that we brush our teeth in the morning and not at 2 p.m.? A lot of this is actually a routine we've been following throughout our life and we're used to. So implementing a routine, a start and a stop time to your day and night is very important to get good quality of sleep. Subtle changes in hours and timing will change the architecture and the sleep quality we get. And our bodies will change behaviors and patterns within 3 days, as early as 3 days. And that's one weekend for some people, or a long weekend, or a holiday weekend. And now you're looking at the whole next week being ruined because our body cannot bounce back with 1 day. You can only shift back 1 hour per day.
Yeah, I was going to ask you that. Yeah. What's the recovery look like?
Yeah. So if you're going to bed at, let's say your normal bedtime is 10 p.m. at night, and then you're going to bed at 1 a.m. Thursday, Friday, Saturday, Sunday, maybe let's say midnight. You're like, okay, I got to work Monday morning. Let's go to midnight. So now, potentially by Monday morning, the hours are not enough and the quality is different. Why is the quality different? Because when your body is deprived, when your brain is deprived of sleep, it shifts the sleep stages in order to put the most recovery stages up front first. So we'll go into L3, which is a stage of sleep where we recover, we restore. Right up front because it's been deprived of enough hours and quality. Whether you're drinking the night before, that messes up the sleep stages, you are just late night foods, whatever it may be, bright lights. So now it's Monday morning. Okay, you're waking up, you're kind of groggy from the weekend. The grogginess is not because you're hungover, if you didn't drink probably, but it's because your sleep stages are all shifted.
Mm-hmm.
So now, on Monday night, you want to go back to sleep to your 10 o'clock, your normal 10 o'clock time.
Mm-hmm.
The body is already adjusted to a new time, and it's starving. So it's going to be hard to potentially go to bed at 10 p.m. And because we can only shift 1 hour back per day, you've been sleeping at 1 o'clock, you want to go back to 10 o'clock, that's 3 hours. You're looking at about Wednesday or Thursday where you potentially may get the earliest sign of going back to your normal sleep stage. That's how sensitive many of our bodies are.
Wow.
This is huge.
Wow.
And no one knows this. Circadian rhythm isn't just this like thing we've made up. It is our internal clock. And it really programs everything and sets intention for everything we do. And it's very sensitive to slight changes. And slight changes become habits quickly. And we can't recover that as quick as we'd like to. Being in mind, lifestyle and work and mom and dad obligation. Very sensitive. So one night of bad sleep can, for some people, disrupt the next week. Now, I'm not saying don't have fun, don't enjoy your life. We've all worked too hard and we've come a long way to do that. But you have to be cognizant of it. Are you someone who's subtle to these shifts? Are you recognizing it as you're getting older or life changes happen that you are more subtle to these sensitivities? You know, we can't stay out like we used to. We can't drink like we used to. Most of that's because the recovery of sleep is not happening like this.
Okay, interesting.
That's what truly that translates as, is it ruins me the next day. It's usually ruined because you're dragging and you're tired, and that's because of how sensitive your body has become to the shifts. And it happens to everyone.
Well, thank you for explaining that. And on the quality night sleep, those subjective assessments, waking during the night, is that and what levels of waking? I mean, like getting up once to go to the bathroom at night versus twice versus 3 times, or what are some of the things that concern you when you hear in a patient, or should we be concerned about if someone's listening to this, be concerned about for themselves or for their patients if they hear reports of certain nighttime activities that may be disruptive?
So in terms of awakening, you shouldn't really be waking up much in the middle of the night. 1, time to use the restroom. 2, if you're drinking a lot of water, but frequent urination at night is a whole list of differential diagnosis for that one. You really shouldn't be. If you're waking up once to use the bathroom, that's fine. But if you're waking up multiple times throughout the night, whether you can get back to sleep or not, okay. Is a problem. So
not like a quick, let's say you wake up once, go to the bathroom, but other times you might just stir a little bit, you reach for adjust the pillow. Does that mean you're not having good deep sleep if that's the case? But if you fall right back asleep, or because some people report, I know I woke up here, I was aware, I moved the covers, but other than that, I was asleep. And then some people wake up and have that happen and they can't fall back asleep for another half hour. So are those two very different things?
Those are two different things, and they're both big problems. If you can't get back to sleep, that's a type of insomnia called sleep maintenance insomnia. You have difficulty maintaining sleep, or you have early morning awakenings, 2 to 4 a.m., and can't get back to sleep. That's insomnia. But you also still should not be waking up, except for maybe once, usually in the early morning, use the bathroom, corresponding obviously with your hydration intake. But in general, you shouldn't be waking up, even if you're able to go back to sleep, or if you're waking up to readjust the pillow. Something is waking you up from a certain stage of sleep. It's not always deep sleep. A lot of people think it's deep sleep, but something is waking you up. And I commonly see this in adults, but more so in kids, where breathing is fine, they're sleeping fine, but they're waking up, they're able to go back to sleep, and there's usually some type of movement disorder going on, some type of abnormal breathing pattern, but it's not so apparent, but they're waking up. It is not normal to wake up multiple times throughout the night, whether you can get back to sleep or not. There are two different etiologies. Insomnia is one where you can't get back to sleep. If you're able to get back to sleep, the awakening is from something. I always trying to translate it like this. If you're waking up in sleep and even if you're able to get back to sleep after the wake up, there's a signal causing your brain to wake you up from a sleep. And what is that? Is it from a muscle switch? Is it from metabolic derangements? Is it from abnormal breathing? Is it from some other parasomnia or some movement disorder? It is not normal. And it's great that you can get back to sleep, because that's better than probably not being able to get back to sleep. But it's not going to allow you to have refreshed sleep, maybe now, but not in the long run. Because what is causing that is not being addressed, and your body will notice it later on. It's not normal to wake up in the middle of the night.
Okay, great. Thank you for clarification. And last thing on the sleep and normality, is it a correct statement that children should not be snoring when they're asleep? A healthy child, absent acute illness, and if they have a cold. But is it abnormal? Is that a concern if a parent says my child snores?
Absolutely. I was just going to say that it is abnormal for your child to snore. I would say it's abnormal for an adult to snore too. Definitely for a child, because we're all more sensitive when we're talking about kids. No, it's abnormal. And I will tell you this, as a lung doctor, I'm not a pediatric pulmonologist. And, nasal inflammation, rhinitis, or really bad postnasal drip and allergies can cause some people to snore. And you treat that, it gets better. I've rarely seen it where you just clear up that nasal inflammation, that rhinitis with your Flonase and your antihistamine, and the snoring truly gets better. It comes back. It usually comes back because it would take severe congestion. I'm talking about difficulty breathing at night to truly cause that snoring, in my opinion, adults or kids. But snoring is never normal. I always say snoring is not normal in a child or an adult.
Yeah,
especially in a child, because for children, it's usually anatomical in nature, usually.
Right.
So we're looking at ENT, and now we're going down your realm. So you guys know it's not normal. I'm sure you see other things when you examine the patient as well. Like I have a lot of patients who come to me for snoring, but the complaints of bruxism and the jaw clenching are all so in line with the snoring as well. So.
Yeah. Sadly, a lot of my colleagues do, because I get in debates with them online all the time, make a lot of statements. And these are highly intelligent people that snoring is fine in kids. It's, if shouldn't be worried about it. Bruxing is normal in kids. It's nothing to worry about. I mean, I hear that all the time from my orthodontic colleagues. So I appreciate it.
You should have seen me when my daughter snored. I freaked out. I need to sleep study. This is why she doesn't listen to me. And my husband's like, no, it's because she's like 4. And I go, that's the best case scenario right now. Yep. The worst case is that she has sleep apnea. Someone diagnoses her with ADHD, puts her on a stimulant, and all she needed was her tonsils out.
Yep.
Or needed, when she comes to the age of palate expander. Because I'm seeing the worst case scenario. I'm thinking the worst case scenario. I know what harm the medication can do. It's not the right diagnosis. The psychological aspects of potentially her, getting put on a medication or sleeping pill, awakening pill, whatever it may be. But yeah, you should see me. I tore the house apart. My husband's like, dude, it's just snoring. I go, well, you snore, but you totally have sleep apnea. I'm diagnosed. This is a whole other talk, But I was like, oh man. I was like, who do I speed dial right now? I need a sleep study tomorrow.
Yeah. Well, I appreciate the quadruple boarded sleep physician confirming that snoring in children is not normal.
Wow.
It is not something we should be okay with and just be like, yeah, it's they'll outgrow it. I love that one. They'll outgrow it. Yeah. Okay. Well, can't we maybe figure out why they're snoring? Because they shouldn't be in the first place. And actually, before I let you go, real quick on wearables with kids, do you think that will get there?
Sleep devices?
Yeah.
Sleep trackers or sleep diagnostics?
Diagnostics, at-home diagnostics.
Yes, I think we will.
Okay.
I think we will, and I don't think we're far from it.
Okay.
And a side note, you may not want this in the podcast, but there is a home sleep study that was just approved for kids as little as 2.
Okay.
The company sent it to me, and I am trying it on both my kids. I have a 2 and a 4-year-old to really see what the data is. I want to interpret the graphs. I really want to see how good it is. Yeah. And that's why they reached out to me, but it was validated and approved that by Knox Medical. So you can contact them. I think we'll get there. And I think that we'll get there real soon. Okay. And more to come, but we all want that. Kids, it's hard, kids' needs and behaviors and fears, et cetera. It would be great to have that.
Yeah, it'd be great. And so, for us on the research side, and it's so hard for us to gather and analyze data pre and post to show what we're doing and the efficacy of it. We can do a pediatric sleep questionnaire. We can have more subjective parameters, the parent talking about the patient and their breathing and their behavior and their overall disposition, right? We can look at the face. If we could have something, I just wait for the day, because it's like we could have this child at intake and say, go wear this for X number of nights, and we're going to log that data, and then we're going to perform this treatment, and then we're going to look at that data again, and we can see a consistent trend in a positive direction. It just gets so powerful for the whole movement. So
the wearables are great too, because you really can monitor treatment efficacy, which is huge. Yeah. I mean, it's so relieving to the patient. It's so relieving to me. It's just amazing. But I think we'll be there maybe even next year. There's been some talk in the sleep robe. I don't know if you guys go to the Academy of Sleep, but the sleep conference is in May, and I think that's a huge one. They're trying, new companies are coming out. There's new talks on that. So more to come on that. It's in June. I'm sorry, June.
Okay. I'm very excited for that. So, well, how can people reach you if they want to reach out, have follow-up questions, or if patients in the New York metropolitan area are interested in coming to see you? How can they find you?
They can call my office or my email. I don't know if you want me to.
Sure. Yeah, say it out, and I'll put it in the show notes too, if you're comfortable with that.
Of course, you can go to my website and put an inquiry, which is Dr. Saema, SaemaTahir.com. It's easier to probably just do that. Put an inquiry in the website and the office will contact you via phone or email, whatever you prefer, to schedule an appointment. Or if you even have questions or you want to be pointed in the right direction, I'm happy to do so.
Awesome. Well, I so appreciate you and you taking the time. You are super busy. You are currently in the hospital, I believe now, conducting this interview, covering there. So I so appreciate it. Just a wealth of knowledge, and it's so great. This, to me, it's one of the reasons why I love doing this, because not only do I get to meet people like you and learn and get more educated myself, to share that with everybody, and then for people to see a physician and an orthodontist having this type of conversation and interaction, breaking down our respective silos and having these discussions. I hear from people all the time through the show, parents and patients and colleagues, and they're like, that allowed me to open the conversation with my ENT or with my orthodontist or whatever it might be. So when people share these messages, share these shows, it really does have an amplifying and somewhat exponential effect. So I really, truly appreciate you coming on and taking your time to have this conversation.
Thank you. Thank you. It's great to collaborate. We know that there's a huge need in sleep. There's a large need. There's a lack of awareness and knowledge and emphasis, and it's great to come together with people from different backgrounds, because this is really what it takes to really address sleep.
Wow.
Truly. So thank you. I appreciate it. This is great.
Awesome. Absolutely loved it. So Dr. Sima Tahir, thank you so much for your time and your expertise. It's been an absolute pleasure to have you.
Thank you.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.